Hello, everybody. This is Lisa Salberg, and I am joining you today with a very special edition of our Tales from the Heart podcast. And today we're going to talk about some internal processes at the HCMA, and I'm going to introduce you to some absolutely wonderful people who are working with us here at the HCMA on our team to help provide you with information, education, advocacy services, and much, much more. So I wanted to just kind of start off with a little bit of a backstory and an understanding of why the intake and navigation calls have become a very integral program within the HCMA and how they can support you and your family. First off, we know that HCM can be very complicated. Genetics, echo, MRI, event monitors, risk assessment for sudden cardiac arrest. There's a lot going on. So when you come into the HCMA, we kind of want to hit the pause button, look at all the data, make sure that you understand your own data, and then help you decide which path forward you might want to participate in. So to start that, we really need to know where each individual stands. And something happened 2 weeks ago at the HCMA annual meeting that I thought was quite poignant here. Two individuals, unconnected, both came to me and said, I was diagnosed 8 years ago, was one, and the other one I think was 6 years ago. But I've never called the office and I've never done an intake call. And now all of a sudden all these things are happening and I don't even know where to start. And I asked them both, would you please write those stories down? We're going to use them in the future. We would like to hear from you early in your diagnosis process. Once we've confirmed your HCM diagnosis, we want to make sure you have all of the resources to help make good decisions for yourself and your family, to use what we have available. If you see what we have available and it's nothing that you're interested in, that's okay. Not every tool is meant for every person. But if we can get you early in your HCM diagnosis process and you understand how your heart is affected, what implications are there for you and your family, and then you can document how you're feeling, we know what's going on, then if there's something that comes up, something changes, and we need to have a conversation or you need additional guidance, we're not starting at square one. You know us, we know you, we know how we're working together, you understand the resources and how to access them, and you are better equipped to move forward through a very complex journey through the healthcare system with your HCM. So first it started with a little note card back in the 90s, and I had a little card collector with little purple note cards. We've gotten a little bit more complicated since then, and the intake process is more specific to your individual needs. And in 2025, it will move to a fully functional patient registry for which you can provide your consent to participate in the registry at any level you see appropriate for you at that time. And that is a really cool new element that we're going to help to understand the unanswered questions. What are we going to do to close the gap further? So Carol will be taking questions in just a little bit back. That's highly unusual. September 25th. Okay, so we're going to be following up on that one, and maybe Ross can take a look at that particular file and see if there's something that we can answer you on before we get off today. So what we're going to do now is I'm going to introduce you to some of our intake coordinators and let them explain to you the process that they're walking you through now. It has evolved into something called a REDCap database, which is a system that was created by Vanderbilt University. It is a very common repository of information system that can be used for research under very, very strict guidance and security. And that's what's really important to us. And as we get all of that information into the system, then we can move forward with navigation calls. So I'm going to bring Linda to the stage and Sabrina to the stage. Welcome, ladies. And I'm going to ask them each to introduce themselves because I think we do ourselves better judgment than somebody trying to explain our resumes. Linda, we're going to start with you and then we'll move to Sabrina.
Hi, everybody. I come to you at the HCMA with a couple of decades of clinical trial experience behind me, from working in a lab through data, through running clinical trials globally. And I decided to make the shift here into patient advocacy because I really wanted to get closer to the patients that we were actually hopefully affecting in a very positive way. So thanks for having me.
Thanks, Linda. Sabrina.
Hi, everybody. I have a master's in public health and health education, and I was diagnosed with HCM. I joined the Facebook group, just like a lot of you, and Lisa decided she liked what I had to say and made me a moderator in the Facebook group, and then later she offered me a job. So I'm really grateful that a bad diagnosis turned into a job offer, and this is awesome. I love talking to the clients on the phone and being able to sometimes be the first person they've ever spoken to live who actually also has HCM.
Thank you, Sabrina. That's a unique perspective. Here at the HCMA, a number of our staff members are also members of the big-hearted community or have family members who are. If they don't, it doesn't mean they don't know what they're doing and it's not a good fit for them. It's just a different perspective that some of our staff have, and Sabrina is one of them. So thanks for sharing your big-hearted status. We'll start with, how does somebody start the intake process?
Clients, patients come to us in many different ways. I would say the easiest and most expeditious way to set up an intake call is to go to our website under education and support, and you can schedule time on either Sabrina's calendar or my calendar that works for you. If you have any computer issues or it's just not convenient for you, or when you happen to think of it, you're only near a phone, you can always call the office and we will set that up for you.
And we try to have live answer phones from 9 Eastern time to 7 p.m. Eastern time, Monday through Thursday, 9 to 5 on Fridays. We try to be available for live answers, but if somebody doesn't answer live, just leave a message and we will get back to you as quickly as we possibly can. The old school ways work too. And I've even had, very rarely, people who are local in the area, well, can I come in and do it? Sure, you can probably come in and do it too. Don't get asked that as much anymore, but it still happens. Once we find out how to set them up, we use a system called Calendly. You can pick your time, you can see the calendar, you can see what's open. The good news is some new Calendly links will start to open up at the first of the year for follow-up calls with our new intake coordinators who are not with us today. They're still in training. So Artie and Maria will be available in the beginning of January to do updates to your intakes, but new intakes will stay with Linda and Sabrina for a period of time. So Sabrina, you want to tell them how they're going to get communicated with?
Well, basically, we ask for a whole lot of information during the intake. And when you make that Calendly appointment, either over the phone where a staff member fills it out for you or by yourself, you'll get an email confirmation. And that means that all this information we're going to share with you today, you don't have to take notes, because your email confirmation is going to tell you all the things we're going to ask about during that intake. Basically, what we would like you to do is refer to this email before your call so you know what to expect. And then at the time of your appointment, you'll call the office and ask for your intake coordinator by name. Sometimes we actually pick up live, but sometimes you're going to go through another staff member. If you are very prepared with your information, we can do your intake very quickly. We can just zip right through and get you off the phone. We're going to need details like the dates of heart tests that you've had, family history, back to your grandparents, aunts, uncles, first cousins. And we're going to ask the hard questions like, how old was your grandma when she passed away? A lot of people trip over that one. You would think it would be other things, but it's not. Basically, though, if you're prepared, we can really get right through.
Some other things that we ask about, too, is we ask about some of your medical conditions, because it may not appear to be related in any way or have any effect on it, but we're really looking at you as a whole person. And I say to Sabrina and she to me sometimes, you know, when do you get an hour of somebody asking just about you? So take this opportunity, and we take the time to database it so that we can help you in the future. The last thing that we ask you for is then to send us a copy of those medical files in a PDF format. And when you have to do that, we send out a really brief instruction sheet on how to do it. But again, if you have any issues, just give a call and one of us will walk you through it.
In the coming months, we will be opening up an opportunity for you to consent to just have your electronic medical records that you choose to be shared with us. You don't have to share all, you share what you need, but the echo, the MRI, the genetic test, they're very specific to you. And when we get to our next stage in this process, the navigation process, this is where you're going to have a really in-depth conversation about your specific anatomy, physiology, risks that you might not know about because you're new to the HCM game. And what our goal is during intake is to get organized. During navigation is to help you with an execution plan for your HCM care now and in the future. If you don't understand the vocabulary, it's hard to make decisions. So we're going to walk you through all of those pieces, both through the intake and the navigation. And when you're done with the two, you're going to feel a lot more prepared for what's ahead of you. There was a great message on the Facebook community today. I did my intake. I learned so much through the intake process. I'm like, yes, exactly. You're going to learn a little bit about what's common in HCM, symptoms that you might be having that you think are weird. We'll go, yeah, we hear that all the time. And you go, oh, okay, I didn't know that that was a common thing in HCM. Linda, what else are you going to be asking for in the intake?
Contact information, demographics, your clinical providers in the event something happens and we need to communicate. When you were diagnosed, how old you were when you were diagnosed. You know, there are some trends in things that happen at different ages in the course of the disease. We talked about the procedures, right? The procedures and the dates.
Is it the first? Is it the second? Is it the third?
Who was the manufacturer of the device? Have you had leads replaced? If so, when?
We're going to be going into every aspect of your HCM journey. So who's caring for you? Is it a community cardiologist? Is it a center? What, dates that you were diagnosed. Women, if you're in menopause, we're going to ask when. There's some triggers that we're looking at with this data. There's a whole bunch of little questions that you'll be asked, that you'll be thinking, what could this possibly have to do with anything? And then you'll see at the end how we're tying it all together. We're also going to ask you questions about how you feel on a good day, a bad day, and an average day. And very few other people in this planet will ask you what your good days and your bad days are like. But when you have HCM, you know what a good day is, and unfortunately, you'll eventually find out what a bad day is. And how they vary and how much time you spend in each one of those classes is important. So we definitely want to make sure that we're capturing your lived experience, your problems with HCM. Sabrina, is there anything else that we didn't really cover yet?
A lot of it is in there. One of the things that we do is we ask about your history of testing for HCM. We'll ask about the approximate dates of the very first time you had an echo, for example. Also, of course, your most recent one and where it was done, so that we can kind of see how long you've been followed for HCM, or even how long ago maybe they could have caught it but missed it.
When you're doing an intake for a child, the parent will do the intake, which is no problem. If the child is 18 or over, that child needs to be present. Their mom or dad can be there with them, but being they're 18, we do that. And actually, if the child is younger than 18 and there's a school issue, the parent can do the intake form, and then we will just make sure the symptom-related things, we get to talk to the child to get that information directly from them.
With the parent present.
Yes, always with yeah.
So it just helps that the parent can sometimes estimate what the child's feeling, but the child may report it differently. So we try to get it from the kids themselves, as that is an important item to capture accurately. So once we go through this whole process, and you've submitted your records, you've got an echo, an MRI, a genetic test with us, then what happens next, guys? How do they find out what happens next?
The exciting next chapter is the navigation call. So we get their test records in, we schedule a navigation call with either Noreen or Lisa, and that is the place where you get your questions answered. You get to walk through your test results with somebody who knows what they're looking at, and just learn a lot about how to be your own best advocate, how to talk to your doctors, what questions you might want to ask.
And you get that education deployed to you through something called HCM Nest. So as you're getting ready for your navigation call, we're going to send you some modules of learning. Let's say, for example, you've never had a cardiac MRI. And we'll say, okay, that's typically included in an HCM workup. So we're going to send you information. What is an MRI? Why do we use MRIs? What information are we getting from it? How to talk to your doctor about ordering one, or how to align with a center of excellence so that you can go there for one. So we're going to give you step-by-step instructions. If genetic testing hasn't been done, we're going to give it to you that way. Very small learnings that then you can also share with others and talk over with family and friends to decide which is right for you. Noreen Dolan,
Yes.
can you please tell our listeners a little about yourself? You have quite the background.
Sure, happy to, Lisa. Thank you, everyone, and thank you for listening. I'm Noreen Dolan. I have over 40 years of nursing and nurse practitioner experience. I've worked in cardiology, cardiac surgery, and 15 years in the Hypertrophic Cardiomyopathy Center at Tufts Medical Center. And later in my career, I transitioned over to Leahy Medical Center and worked in their HCM center and helped transition from Tufts to Leahy Hypertrophic Cardiomyopathy Center. I was a practicing nurse practitioner. I cared for thousands of patients with hypertrophic cardiomyopathy, along with world-leading experts. And last year, I decided to retire from clinical practice as a nurse practitioner. I've known Lisa. She's been a friend and a colleague of mine for many years. Lisa reached out to me and asked if I was interested in changing roles, changing my role as a nurse practitioner in the clinical setting and working as a navigator for the Hypertrophic Cardiomyopathy Association. It didn't take me long to say yes, because I would very much miss patient care, and I thought it would give me a great opportunity to stay with the HCM community, and hopefully my experience and what I know about HCM can be of help to the HCM community. So it's been a pleasure thus far, and I really enjoy the team, and it's been a pleasure speaking to our community and hoping that I can be of help.
The backstory for everybody is I found out she was retiring, and I went, I can't lose that skill. Oh my goodness. I wonder if she would. I remember sitting in an airport lounge. I was about to take off for Brazil, I think. And I'm like, Noreen, I have an idea. Let's do a thing. And it took a couple weeks to get it organized. And I had Noreen mirror me on a number of navigation calls over a couple of months. And it's an interesting line between clinical practice and navigation. I'd never had anybody watch that before, especially somebody who is a nurse practitioner. So seeing the line that I was drawing as an advocate and a navigator, and where Noreen would go to the clinical practice, we found that line. So Noreen is not going to be your nurse practitioner. She's going to be your navigator to help you understand your anatomy, physiology, and treatment options, and maybe also help identify resources to help you better understand or better learn about your disease, or find a physician that's more likely to fit in with your needs. Noreen, when we go through a navigation call, would you agree that one of the most important pieces of information that we have is that echocardiogram to understand where people are coming from? What do you glean from the echo when you're doing a navigation call?
Well, absolutely. With the help of Linda and Sabrina, as you just mentioned, prior to the phone call, we do receive their echocardiogram report, as well as if they had a cardiac MRI, their cardiac MRI report. I look very carefully at the reports before the phone call, and I usually am prepared in terms of what would be important to them, in terms of how thick their heart may be, or certain parts of that report that would be important to them. So that, as you already articulated, about their anatomy, their own unique anatomy, their own unique morphology. The HCM, as you well know, there's subtle versions or there's subtle forms to the more extreme forms. So those reports can help me prepare for the phone call. In terms of the phone call, oftentimes patients know somewhat about HCM. And as Lisa, you already had mentioned, we take care of all patients, those that just learned that they have hypertrophic cardiomyopathy. So that phone call may be a little bit different because they need to know the basics. So we will educate them, help them understand as best possible some of the basics about HCM, because as you just stated, it can be complex, confusing at first. There's a wide spectrum of patients that we will speak to on the phone, those that are newly diagnosed, or those that may have had hypertrophic cardiomyopathy for years, and maybe the current treatments that they're on right now aren't working. So in terms of the echo specifically, oftentimes the language is confusing. It's a little bit scary. It's a lot of medical jargon. And we will, with the patient, if they wish, with the client, I should say, we will break it down into more relatable terms or terms that they can better understand. Sometimes when they have the report, they may have already met with the doctor, or they may have already met with their healthcare provider and they were told, oh, your echo's unchanged, or your echo looks the same as it was last year. However, that report, the language is very confusing, highly technical, and they may get anxious or nervous. So we are a great resource to kind of break down that medical jargon into a more relatable, easier to understand way that they can relate to. In addition, rather than going through every single data point, I try to have them focus. Let's zone on the things that are important to you. What is there that's abnormal or that is consistent with your HCM that's expected? Or there may be some language on that report that is a little bit concerning to me or out of the ordinary. Or maybe the wall thickness is a little too extreme for me. Or maybe I saw that some decrease in the heart squeeze. I will ask them, have you spoken to your doctor about this? I see that you may have a change compared to last year. And oftentimes they will say yes, but they didn't understand the change. So I try to give them more clear, accurate interpretation of it, something that they can relate to. And if it hasn't been explained to them, or, oh no, this is a new change, I will recommend that they speak to their healthcare provider about that change. Lisa has already mentioned this, where I am not performing as a nurse practitioner. I am a navigator. I'm here to help maybe provide clear and more accurate information to them, maybe break it down into relatable terminology, but I'm not assuming their care, and by no means are we replacing the very important care that they need from an HCM center of excellence or their own local doctors. We can just help educate, listen, and maybe educate them on their own heart and their own heart's unique characteristics, because no heart is alike. Those reports are important. They're not the actual imaging, and that imaging will be looked at and reviewed by your doctors, but we can certainly help break down the report in more patient-friendly,
More comfortable.
that they can understand. And then, oh, I get it. Oh, it clicks now. Thank you for explaining that to me. Whatever data that you have, if it's sent, this is an age of transparency, medical transparency. So all of our patients receive their medical reports either through a portal or by email. And those reports can be extremely confusing. So if we can help break it down and actually help them focus on the important parts, and let's address the important parts and how it relates to you as a unique individual and how it will relate to your treatment and your future health care, and what questions to ask your doctor at your next visit.
So let's go back for a second. That echocardiogram can be really kind of a temperature check. If you get an echocardiogram from a community doctor that says normal or HCM, and that's all it says, we don't have any numbers, we don't have any narrative, it's just very, very surface, and they just label something. This is an indication to us that we need better imaging conducted. We need to see this anatomy, and then we can make recommendations to either go back to your doctor and ask them for the full report, or just move on to somebody who understands HCM better and establish some new care. Looking at resources, we also have our online discussion groups where patients can meet with other patients in a peer-to-peer group, whether you're going for a myectomy, getting an ICD, considering new medications. You can actually go talk to peers as well as go to one of our centers. Everybody learns in a different way. Some of you are learning by listening to this podcast. Some of you would rather watch us in a podcast. Some of you would rather attend a webinar. We're trying to educate you wherever you want to be, however you want to learn. We're trying to bend to it. And Noreen's role in this is to help identify what's going on with you, help you become the best advocate for yourself and your family that you could possibly be, and to put you into this battle armed with all of the information and knowledge of all of the tools in your toolbox that apply to you. Example, I've had people contact me and say, I really am interested in gene therapy. Well, have you had genetic testing? No. Do I need to start with that? Yes. And maybe they have an unidentified mutation, so no mutation found. Genetic therapy is not the place we should be starting because it's not for you yet because we don't know enough. But if you're obstructed, you may want to know the difference between a myectomy, an alcohol septoablation, or a myosin inhibitor. What are the pros, cons, advantages, disadvantages to each? We can give you general information on this and why, based on your anatomy, these may be good or not good options, but here are the things you can ask your doctor to elucidate which is your best option. Noreen, how many people do you feel, I know what my number is, how many people have you worked with either in nurse practitioner or patient navigation with HCM over the past, 15, 18 years?
It's in the thousands for sure.
I was going to say you're probably around 5K if I had to guess.
Probably.
Mm-hmm.
So I've seen it all. I mean, I've seen, young patients who were recently diagnosed up to the age of 90. As Lisa just mentioned, no patient is alike. One size does not fit all. There may be patients that are non-obstructive. We can give them the information on the knowledge about what treatment options are available for that group versus those that hear about these new commercials of this new drug that you may be a candidate for if you're obstructive. So it is important, as in our roles, Lisa and myself, to zone in and to concentrate on what's important to the patient. Patient may have a very specific question, or patient may not have a good understanding of what's an obstructive heart versus a non-obstructive heart. And I think that Lisa just brought up a good point. Patients learn from different ways. At times they go to a center of excellence, which we strongly advocate that you be seen at a center of excellence, and they may have an hour's worth of education about their heart condition and their heart morphology. And that's not enough because it's so complex. And then they'll go to the website, they will take advantage of all the learning tools, and they'll take advantage of the patient interaction groups on the websites. And even sometimes that's not enough. I've known through all my years of clinical experience and working with world leaders in the field that patients sometimes they learn by hearing the information not once, not twice, sometimes 3 times. And that's okay. That's very common in our world, that you're not going to learn everything about hypertrophic cardiomyopathy in a 1-hour visit. You're not going to learn about it all on the website. And sometimes you have specific questions related to your unique characteristics that myself and Lisa can help you and can give you that knowledge and that really clear and accurate information that you need so that you can make great healthcare choices for yourself when you go back to the doctor.
So I used to do all the navigation calls. I do very few now. Noreen does the majority. I take care of pre-transplant, little kids, and foreign ones, mostly like out of US, because the access issues are a little bit different there. But Noreen and I talk every week. What's going on? Do you understand? This is what's happening with these clients, and we're in constant contact. But people will ask us the question, well, what would you do if you were me? I will never answer that question because I can never be you, nor can Noreen. We will give you things to think about, and we will give you things to question yourself about. What do I want? What can I do? It's us helping you come to some decision making. What I might choose may not be the right thing for you for a lot of reasons, and Noreen as well. So we can give you hypotheticals. If my situations were similar, maybe I would do this or this, but you're going to make the decision that's right for you and your family. There is not one theory that we believe in that is right for every single patient with HCM. Not everybody needs the same therapies. Not everybody needs the same risk evaluation. Well, they all need the risk assessment evaluation, but there may not be anything actionable at the end. You may be low or mild risk, and you have to know what that means, and you have to accept that. And this is all part of a concept in healthcare called shared decision making. Now, from the doctor's side, shared decision making means one set of things. On the patient side, it sounds like we get to decide whatever we want, and we get to pick the orange cupcake versus the pink cupcake. No, your anatomy and your physiology, your genetics, your timing in life will determine what might be available for you. And if your anatomy is not right for a procedure, you can't will it to be because it's the one you want. Your anatomy may not respond. This comes up oftentimes with alcohol ablation versus myectomy versus myosin inhibitor. Maybe you want to try something and see if it works, and then if that doesn't work, try something else. There's a logical cadence to this, and not every anatomy is appropriate for alcohol ablation, and not every anatomy is appropriate for a myectomy, and not every anatomy is perfect for a myosin inhibitor. You need expert guidance on that. And as long as you understand how to evaluate the variables and you understand your choice in care, that's where shared decision making takes a flip. And it's you telling the doctor, like, I have a business trip coming up in January I've got to be at, and I'm not feeling well now. I don't know if I want to start a new medicine right now, or I just want to optimize my care until at least February, and then we can maybe look at new treatment options. You have to value it with what's happening in your life. You have to, you have to evaluate your access to health care right now. And I'm going to say something on the 7th of November, 2024. If you are insured by an ACA plan, please optimize your care now. I'm not sure what's going to happen 2 years from now, and whether we'll all have the same access to healthcare as we do today. Will it be better? Will it be worse? I don't know, but I suspect it's going to change. So you have to look at where your healthcare is today and what you have access to today so that you can make decisions for today and tomorrow.
I think that you addressed it quite well. And I think when an important point is when our clients in our HCM community do call us, that both myself and Lisa are very current in terms of what are the latest guidelines in the care and management for hypertrophic cardiomyopathy. We stay quite up to date with the science and the clinical trials, what is upcoming. We consider ourselves a great resource to you, but again, we're not replacing your local doctor. But as I've mentioned, and I continue to believe this to be so true, patients cannot get enough information. But I can assure you, we're pretty consistent with the centers of excellence. Our message is very consistent with those centers. We're not replacing them, but we may be explaining it to you in a different way. As Lisa mentioned, this shared decision making, and you're unable to make the decision, but maybe you do have reasons like a trip or whatnot, but you need the knowledge, or you need to understand the three options that were given to you so that you can make a good decision for you. We're here to give you the information, to help educate you so that you get it. It's like, aha, oh, now I get it. Now I know what to ask my doctor at my next visit, or now I know what to present to him. We're here for you. We're on your team. We're on your side. Our message is very consistent with the centers of excellence, and we work really hard to stay relevant, to stay up to date with the latest treatment strategies, also all of the science that Lisa just mentioned. Patients sometimes think they may be overreactive or too bothersome, and they're concerned about calling the doctor too many times. And I can't emphasize enough that when you do go to your cardiologist, or you do go to a center of excellence and a new treatment's been tried, you need to ask them, like, when will I see any difference? Or when will I see a change? How long do I wait before I see a benefit? Or when should I call you back? These visits to specialty centers are usually annually, but if there's a change in your clinical status, if the drug that has been tried doesn't work, because every drug doesn't work for everyone, and sometimes you need to try other therapies. And the docs in the community, as well as the centers of excellence, they want to hear from you. And there's lots of things that can be done, believe it or not, over the phone. We do believe in a comprehensive, we believe in support that you be seen at a center of excellence for a very thorough, comprehensive evaluation in terms of your risk, in terms of treatment strategy. But in between those visits, there's lots that can be done to help you and your symptoms that could just require a phone call. I also have patients, lots of clients, and Lisa can expound upon this, that they want to know what they can do so that their disease or their condition doesn't progress. What can we do? I feel great right now.
How do I stay here? I'm good.
Yeah.
So we can do our very best to try to keep our bodies in good shape. We can exercise, we can monitor our weight, we can do all the good things that we're supposed to do. And even if we do all the good things, sometimes we end up, needing a heart transplant. Hello. But that's only 5% of the population. So the goal really is, how do we maximize your quality of life, your health, and map it with the life you want to live? Not the life that HCM has carved out for you necessarily, but what do you want to do that you're unable to do now? We want you to define that. We want you to attack it with your team and improve your life to the greatest degree possible. And now for everybody, it's not going to be, going back to how you felt when you were 35. I'd like to feel like I felt when I was 30. Well, maybe not. I'm not sure. With realistic expectations. We do age. Joints do get weak and sore and swollen and break, along with our heart gets a little bit older. So how do you gauge what you really want to do versus what you can do? And how do you optimize your care? In 2024 HCM, there is nothing but promise ahead for us. New drugs, new therapies, new procedures. It's not ending right now. Things are going to get a lot busier here, which for those of you who've been hanging around a while, there's new faces, there's new names, there's more people. I am introducing new staff members. We're hiring a communications manager right now. There's all kinds of stuff happening here to serve you better. And I know there's a couple of you who have contacted me and said, but I want to talk to you, Lisa. And I say, I really appreciate that, but I'm there behind the scenes helping the entire team learn and grow. And I'm taking all of my best practices and I'm hiring people who really understand the assignment and are kind, compassionate, empathetic, and smart as whips, all of them in their own ways. And we're going to build a bigger boat to get you all on the boat so you know where you're going. So you're going to see some new people and you're going to hear some new names, and we're all going to build this together, and we're going to make sure that you and your families have all the resources that you need to do good things. Now, I'm going to bring back Linda and Sabrina. We understand the why we do the intake and navigation call. We understand the roles of it, and that we're all here to provide leveled education and engagement with the patient. What do I mean by leveled? If you don't know what hypertrophic means, we're going to sit down and explain it to you. Then we'll go to the next step. Cardiomyopathy. Do you know what that means? You can say no. And we're going to say, okay, here's what we can help you with an understanding. Doctors will throw scary words at you. We want to put in an implantable cardioverter defibrillator. What? We'll break it down for you. We'll make it make sense. Somebody in your family told you if you just exercised more, you wouldn't have heart problems. We're here to tell you, no, that is not true. This is what HCM is. You didn't do anything wrong. You didn't. We're here to balance it all out, set you up for success and answer your questions, and prepare you to ask your care team tough questions that are going to help you understand what's next for you and how you can most optimize your health. Did we miss any part of the intake navigation process? Sabrina, you're a patient with HCM who went through this process. Could you give us a perspective of, those many years ago, what it meant to you to do an intake and nav?
I was a weird patient, so I may not be exactly the typical, but I think that going through the process is a great way to learn about your HCM, right? The questions that get asked during the intake and the things that are discussed during the navigation call are so specific about you that you may never have thought about it before. You may never have been asked that question by a doctor, but we're asking. And it makes you think, oh yeah, I did have that one relative that had rheumatic heart. Maybe that's where it came from.
You become your own health detective.
Yeah.
So if you like detective stories, we're really good at those. And we're unraveling mysteries here every day. Like, what is going on? How do we make this person feel better? So Linda, you came from the pharma background, and we tend to lose people to pharma, but we got one back.
I guess I'm weird just like Sabrina, huh? I'm going upstream. I'm swimming upstream. Two really impactful things for me. One is to have people remember that as sophisticated as medicine and technology are, it is sometimes much more an art than a science. What doses are you going to wear, or which combinations, or maybe you have to try this. And we all want answers right away, obviously. So that's number one. The second is one time when I said to somebody that I did not have HCM, when they asked me, they said, and I was like, I know, I feel like just half a warrior because I don't have the disease. And they said, no, we need people with all that energy. We need you. You're not a half a warrior, you're a warrior and a half.
That was great. Noreen, you have a really unique perspective now. You've been in clinical care of this patient community for a long, long time. And then when you came over here, I used to tell people, you'll know when a patient's been through the HCMA when they come to clinic. And now that you see what we were doing to prepare them, did it make a little bit more sense why some of these patients came in like talking like doctors?
Oh, absolutely. When a patient, it was even on the medical record, spoke with Lisa, and we knew, we better be prepared. Patients would come informed. They had great questions. They came prepared with a better understanding, at least the groundwork about HCM, so we could add upon it. So it made the visit much easier for us. And oftentimes patients would come saying, I think I spoke with Lisa. She wasn't diagnosing, but she was concerned about the scar and thinking that I might need an internal defibrillator. And of course, we would go through everything. And sure enough, yes, the patient did need that. But they were prepared. They had the information. They understood why you would need an internal defibrillator, or they would understand if someone was struggling with symptoms and tried medical therapy, why you were thinking, well, maybe they should talk to their center of excellence about a surgical intervention. So I found that patients were able to be their best advocates, and they were empowered to ask the questions when they went through the HCMA. They came with some great knowledge. They were empowered to ask the questions, and they had a better understanding. So I think the visits went easier because we weren't shocking them for the first time. I can't say enough what a valuable resource this is to the HCM community. There was a big difference in those that had the education, their own specific questions, and just had the knowledge so that they could be their own best advocate during the meeting.
I think having them prepared, having them ready, we hear these words. And, I get just, if I had an imagery, it's like a cat jumping up and getting stuck on the ceiling with all their claws extended. And they're like, what's going on? That's what we feel like up front. And sometimes maybe that's a very internal fear that we're having a hard time articulating. Maybe we're very emotional about our diagnosis. We've seen it all. It's almost impossible to shock me. And by extension, everybody else has kind of been exposed to everybody's different way of dealing with it. Some of you get angry. It's okay. You can be angry. We can talk through the anger. You can be scared. We can talk through the scared. You can think that everything's okay, but know that you really should do more work and find out. The most upsetting thing that I could ever be told by somebody is, I know I have risk factors for sudden death. I just don't feel like I'm going to die. And I wish I could say that all of those people eventually called me back. But some of them just didn't feel like it was going to be them, and it was them. And risk factors matter. The science matters. This is not hocus pocus. This is not a couple of docs sat in a room, wrote some stuff on a cocktail napkin and said, this is the way we're going to do this medicine stuff. This is 60 years of dedicated research within the United States, 60 years plus. It started in 1959 at the National Institute of Health, before it was called the National Institute of Health, with Eugene Brunwald and with Dr. Andrew Glenn Morrow. They're the ones who started this whole movement Claude Brady, the first patient ever diagnosed with HCM and dear friend to the organization until his passing in January of 2022. Diagnosed in 59, lived to 22. That's pretty extraordinary. So many patients can have good outcomes. You have to listen to the facts and the science. And I suspect things are going to change a little bit in terms of how we validate data coming up. And we have to know that in HCM, we have great researchers. We have good clinicians. We've got great science. You got to follow the science. So we want you to be able to understand your individual science. You are a science experiment of one. I always tease that I'm the most complex chemistry experiment that I could possibly create post-transplant. But it takes this very magic mix to get me to work very well. So what's your magic sauce for your HCM? How do we optimize your care? This team is here to help you. These people are here to guide you. They're real people, like real human people that actually pick up the phone and like we talk and we hang and we do all the people-y things. We're not a big corporation. We're not here to get your data to use it inappropriately. It's there to help you. You will decide as our patient journey registry is brought to life. It's going to the IRB as soon as I can get a couple of elements together to get the submission in, hopefully maybe even this week. So once we get our IRB approval, you will all be called back to be consented in at whatever level you would like to be part of the registry. It may be for internal purposes only. You may want us to be able to share your de-identified information with our clinical partners or our academic partners, or you might be interested in collaboration with industry. You get to choose the level of your consent, and we're going to walk you all through that process, and we'll have another podcast about that when the program launches, and we'll introduce you to the two new members of the team who will be doing most of the callbacks to do the consent for you. So I see a couple of comments. Are there any updated research on women perimenopausal? No, there is no data on menopause, premenopause. There is no data at all about the interaction between hormones and hypertrophic cardiomyopathy. It is an area that we are interested in. And as our patient database grows, we'll be able to collect information on those unique items, such as this, that the research community hasn't quite delved into yet. There's another one you've been asking for a while, and that's about migraines. So we're kind of waiting till the IRB is approved before we launch these so that we can actually publish the results. So migraines and HCM, what are the roles of migraine with aura versus not? Is there a cardiac component? I have absolutely no idea the answer to that. I can just give you an N of 1. I suffered with migraines my entire life. I got a transplant. I don't have migraines anymore. Is it a blood flow issue? I don't know, but we're going to get enough information together and enough experiences that we're going to get the research community interested to go, what's the connection? We're going to do the same with hormones and premenopausal women, postmenopausal women. We're going to look for what are the good day, bad day things? What is that all about? How do we measure that? How do we make it stop? How do we just have the good days and the better days, not the good, bad? So how do we do that? The database is going to lead to a lot of answers. At this time, we have 7,800 individual patients in our database that we've talked to over the past maybe like 4 or 5 years. And some of the older ones, those old files, we're going to try to rekindle those old files and get some of those old people back in before we went to digital. But if we can get 8,000-10,000 consented over the next 2 years, 3 years, we're going to have the biggest repository of data on patients anywhere. And it's going to be center of excellence care, community care, international care. So we're going to get the big picture. And these lovely ladies on the screen right here are going to help us get to those answers. So don't be afraid of them. Intake is not a bad word. It helps us help you, help yourself. And we can't wait to have all of you call and do intake calls, but don't all call today. Linda, final thoughts?
It was great to be here, and I look forward to either doing your intake or seeing you on one of our webinars, like the newly diagnosed, and be well.
Sabrina?
I look forward to speaking to as many of you as are willing to come and do intake. And I just wanted to say that I think our superpower at the HCMA is reducing anxiety with education and also a lot of empathy.
Great point. Noreen?
I think no question is too trivial. I encourage our community to give us a call, that if it's important to you, it's important to us. We also mentioned something about healthcare access. Some of you are not within a geographical area of a HCMA Center of Excellence, which is a struggle, and we will help you in any way we can, whether it's getting a virtual visit with a Center of Excellence for a comprehensive visit, or helping work with your local cardiologist, or confirmation to the client that, yes, you are receiving state-of-the-art care. I think every one of our clients, everyone in the community who has hypertrophic cardiomyopathy is very deserving of a very comprehensive, thorough, state-of-the-art evaluation for their HCM. And we, any way possible, we can help you, provide you numbers to centers of excellence within your area. And we can also fill in the gaps, as Lisa had mentioned and the rest of the crew have mentioned. If you have questions or concerns, or you need further explanation of the treatment therapies that are available today, we know them, we keep up with the science, and please give us a call. I do find that patients and clients are sometimes relieved to know that they're not alone. They didn't cause it. They did nothing to cause it, which was an important point that Lisa made. And there is some sense of relief in speaking with us, because we do have a level of expertise that can somehow complement your physician visits. And so I look forward to speaking to anyone that calls, and thank you for this opportunity.
Thank you. So that wraps up a solid hour of talking about intake and navigation. This, if you've gotten to the end of this, thank you for sticking with the whole thing. I know it's a bit of a dry topic. It's not like some sexy new, treatment option for HCM. It's just the nuts and bolts of how we do what we do and why it's effective, and why a little bit of your time to invest in yourself. This is self-care at the highest level. We want you to be armed with the information. And even if you don't feel like you can handle learning all the idiosyncrasies, we can help you figure out where your focus needs to go, what questions you need to ask. And then if you don't know something, you now know how to get the answer. And we've got a relationship and we have context. We know what you're dealing with. It's really easy to answer a question that way. I do want to cover one last topic before we close, and that is, somebody just a few days ago said, why do I need to do an intake call? Can't you just answer my question here on social media? No, I can't. Because your anatomy and your family history and your symptoms and your experience are going to be different than something else. And if any of the equation is off, if we try to give you some guidance, we have a really high likelihood of being incorrect. Mm-hmm. And I don't like to be incorrect. I like to be really specifically accurate. That's what we focus on. It's labor intensive, it's expensive, it takes time to do, and everything is worth it. It works the way it works.
It's one quick thought about that. Another real life example that happened one day, that I got a call from somebody who was in the hospital. And they just reached out to us in the hospital. It was their first time ever calling us. And exactly the point you just made, I was saying it would be reckless for us to do something, but please, that's why it's so much better to have that early on, so that we have something now. Even if it has to be updated when we talked about, we have something.
So don't be afraid. These are real people. We're nice. We're not going to say, oh my God, you don't understand that? How could you not understand that? No. We're going to say, how can I explain it to you differently to help you understand it better? And if it takes 10 times, we're going to take the 10 times to make you understand and help you get to understand. So on that note, I thank my amazing team, without whom I wouldn't be able to do all the amazing things that I'm able to do. So trust the process. We're here to help you. We hope to talk to you all very soon. Have a great day, great Thanksgiving season. And if you are in the Chicago area and a member of the American Heart Association, HCMA will be on site there shortly. So remember, this is November 2024 that I'm posting this. And the first weekend in December, December 7th, we're going to be out in San Francisco. Linda will be with me, and we're going to do a meet and greet. And Sabrina will be there for part of it, but she's got to go sing some, Dickens songs or something and dress kind of cool. One of her sideline jobs. So we're going out there doing a meet and greet and mini meeting with some updates for the South San Francisco area. Registration is now open, so if you want to come on out, it's an 11 to 2 event, beginning of December. And we got lunch. So come on out and hang with us and learn and get involved in the community. And we'll look forward to seeing you there. Tomorrow, Tales from the Heart. David Light and Harry Lever discussing generic medications in the United States. Very interesting topic. Tomorrow morning, I'm going to be talking to Marty Marin. He's fresh off the summit. We're going to talk about what we've learned, where we're going, and just how we're going to take the next bite out of finding the undiagnosed. So join us tomorrow at 11 a.m. for that podcast. And we look forward to seeing you all through your intake process. Thank you, ladies.
Bye-bye. Thanks.
Bye. Bye.
The Hypertrophic Cardiomyopathy Association thanks the following sponsors for today's podcast: Cyokinetics, Bristol Myers Squibb, BioMarin, Tenaya Therapeutics, Viz AI, and Alnylam.